Hi, everybody. While the pooch is quiet, and who knows how long that'll last, I am. I just wanted to. I wanted to leave basically Friday to diabetes, and then if I have some time, introduce blood before we do the blood lab. I hope we'll have enough time to do this. And we were well into this endocrine. I was actually going to do that and probably try to get through the diabetes on Wednesday, but I just couldn't be there. So this is just trying to supplement it a little bit. We kind of left the thyroid. I didn't want to give it short shift. Very well vascularized gland. It's just important for everything. You look up thyroid function on a table and what it impacts. Basically, it impacts all systems. So as long as the thyroid functioning properly, everything else functions properly. And the big deal about it is the concept of understanding that the iodine is the critical piece. We need a tiny amount of the mineral. You can get it. It's the reason why we use iodized salt, because people had goiters and it was impairing their thyroid function, because the thyroid gland produces the colloid, the precursor substance from stimulation from a thyroid stimulating hormone. But in the absence of iodine, all it would do is accumulate. And it's effectively a vicious cycle. Your body does not see the T3 and T4 in the bloodstream circulating. It keeps signaling to make more, and in the absence of iodine. So what happens in the presence of iodine, then, and this is just as it says here, is the major metabolic hormone. Okay, and again, the interesting thing is the symmetry aspect of effectively these two tyrosine molecules that have either 3 or 4 iodines in them. And you can see, even though perhaps, as you can see, at the tissue level, it gets converted to T4. Every cell in the body, and because of the intracellular receptors, similar to steroidal or lipid soluble based hormonal agents, this effectively affects transcription and translation. Generically calorogenic, everything. So, I mean, whatever way you want to look at it, whether it's cardiovascular, whether it's skeletal, whether it's reproductive, all of those are important, as well as maintaining appropriate blood pressure. So it's rather simplistic. It's just made effectively by these, more or less a type 1 type of a cell, a primary follicle cell would be the way to describe it. It's discharged into this lumen, so to speak. We call it thyroglobulin or colloid because it pulls water with it. And then the iodine are basically transported in and released into the same area. And then effectively the iodine is then basically converting it, as you can see, the iodine ions are conveyed to I2, and then we begin to attach them by a variety of enzymes. You can see certain enzymes in peroxidase do play a role in this, so it's another role for peroxidase enzymes and almost implicit in peroxisomes. And you can see there's different forms of it, but eventually the single iodine and the double iodine forms are linked together to form T3 and T4. And those are the active units. So, and it's fairly straightforward. Basically, the enzymes cleave T3 and T4 from the thyroglobulin. It gets eventually secreted and exocytosed into the bloodstream. It's an endocrine agent. It travels through the bloodstream. Okay. And I should have picked up on that. Apologies. The T4 has to be not T3 at the T4 at the tissue level, but T3 at the tissue level. I don't ask about that, but the reality is that's an important little note for if you're going to be taking tests further forward in whatever field you're going to, or GREs, assuming they still require those things. If you're going into graduate studies, be aware of that. Okay. And this just gives you an idea of exactly, and you can see the difference here between T3s and T4s. I mean, it's just a question of how many of those little iodine blue nuggets that they have on there, and then eventually they're released into the bloodstream. That's all well and good without going through all that goes on here. And because of its fat solubility, it doesn't travel so well in the bloodstream. So we have to have certain globulins. As you'll see when we get to the blood unit, We have different kinds of globulins, and effectively certain kinds of globulins are dedicated to the immune system, while a great many globulins are dedicated to being effectively carrier molecules in the bloodstream for fat soluble products. Okay, as you can see, T3 is much more active. Okay, and when you finally get into the tissue areas itself, T4 can be converted to T3 just by removing one of those iodines, and again, that's the most active form. Same thing with negative feedback. Rising thyroid hormone levels are the negative feedback. TSH can also be inhibited by other things. So if we're inhibiting growth hormone for that particular purpose, we have less need for thyroid. Dopamine, so we're having neurological functions, and and you can detect levels of that as well. And cortisol and iodide. So if we have ample amounts of that, we really don't have to uh, provide extra stimulus for this. And again, the hypothalamus is where basically overcomes this to a certain extent with an appropriate release hormone. So you can have direct action on the thyroid, and plus we have releasing hormone, which can overcome the negative feedback during pregnancy, exposure to cold, especially in infants, as you can see, because it's their way of generating warmth, if you want to think of it that way. We'll see more about it when we get into pregnancy is unusual, and then and it kind of dovetails into the when we talk a little bit next time in class about gestational diabetes that are there. So here you can see the areas where the thyroid hormones can induce certain degrees of feedback, either directly or indirectly, and we can see certain degrees of stimulation that's there as well. So, principally, I would think that the hypothalamus provides the thyroid release hormone whenever these levels drop that are there. And this is the chart I was referring to previously about all of the effects associated with the thyroid. So, you can see, name a system, effectively, it's there. So, basal metabolic rate, nutrient metabolism, nervous system, cardiovascular, musculoskeletal, GI, repro, integumentary. Pick one. So effectively, they're all involved with this. You don't hypothyroidism, to be fair, I think is less common. And typically it's a result of damage to the thyroid. See, thyroid's a busy gland. And when tumors develop in this benign or malignant, normally when you look for a tumor with a scan, you look for what's called a hot spot because it's increased activity. Thyroid is always hot, so we're looking for cold spots. And so, if you have to remove a thyroid, particularly in the event of a cancerous tumor, effectively you're creating a hypothyroid type of situation. But thyroid supplements have been around forever and continue to be, and they're relatively straightforward in how to monitor. But there are some folks who are just programmed low with this, and these are and you may be and does it contribute to people with problems with overweight or lack of energy, overly dry skin, very sedentary lifestyle. They just don't move around. All those things, constipation, cold all the time. And we do see a lot of edema. And this is not cardiovascular edema. This isn't due to the heart not functioning properly and fluid sort of backing up and extravasating or leaving the bloodstream in gravity, particularly in the lower extremities. This is a little bit different. It's not so much fluid, it's a little bit more solid and almost lethargic. And sometimes we erroneously label people who are like that, and they may have an underlying thyroid condition, or you may have somebody says they have an thyroid condition, and in reality, they're just not very active, and there's a lot of unpleasant words you could describe them with. Now, if it's goiter, and again, we don't see it in developed countries nearly. We all have a sufficient amount of exposure, even if we occasionally use if we use any pre-made food or a canned good or something that has any kind of salt in it, there's going to be a certain amount of iodized salt. I mean, at home, if you're buying just standard iodized salt, you're going to have that. But if you want to you can get more specific salts that a lot of us use in cooking. If you like Himalayan pink salt or sea salt or gray salt, and even kosher salt, which a lot of cooks use, a lot of chefs use. There's all different salinity things developing in it, and you can always get those with iodination if you want. Okay, so thyroid hormone levels, and then what happens is you just, again, it's this cycle to create the unusable, and the thyroid enlarges. I'm going to show you a picture. So normal growth, brain development. So here, there are some congenital means you're born with this particular problem, and there are different things that can be part of it. And then this is the type of workup that's done pediatrically when you're looking at certain medications and certain aspects of the mom and what goes on. It's very tricky, would be the best way to describe it. That's why, if you're looking at somebody who's into neonatology or looking short pediatrics, there's a lot, because when kids aren't developing properly, you really have to try to find out the reason right away. So you can see just some of things. And so it's early. And once you identify it, then again, thankfully, the availability of thyroid hormone is there. That's a classic goiter. Now, you can mistake them for a tumor, but effectively they're fluid filled. And it's a relatively easy diagnosis that you would be able to see, because you can see the fluid, you still see a lot of activity. Again, thyroid tumors are cold. In other words, on scans, they show inactivity. This is interesting. This is an autoimmune phenomenon, and it's unusual because usually if it's attacking the thyroid, you wouldn't expect the thyroid to function, but actually, immunologically, it's really sort of increasing it up. In the autoimmune disease, the body makes abnormal antibodies directed against the follicular cells, but the antibodies act like TSH. So it's sort of paradoxical. And I always think paradoxical things are, you need to remember, it's got a great name called Graves' disease. Just why I always remember it, because my wife's last name is Graves. So we have two different last names. Okay. So it's easy to remember. And so because of that mimicking it, and these are hyperthyroid. And this, you see, we used to call these the old type A personality people. People who they just couldn't settle down. I mean, probably nowadays they just overdiagnose ADHD and ADD. But the reality is they have an elevated metabolic rate. It would show up on laboratory tests. There's a greater amount of perspiration. You have heartbeat. The nervousness is sometimes difficult. And typically they tend to be, we call them hypersecretors. You'll have acidity problems in the stomach. You have perspiration. When we used to see, people with sweaty feet, in the back of your mind, you go, I wonder if it's hyperthyroid, or if they, and a lot of times it has nothing to do with that whatsoever. So you just sort of keep that in your back pocket in case you have to do a workup. And this is sort of the tell or the giveaway. It's called an exophthalmic goiter, because they become the area behind the eye, that sort of fatty and fibrous tissue, for whatever reason, becomes edematous, and the eyes protrude. You'll see an illustration of that shortly. Okay. And there's lots of ways that you can address that. And then once that thyroid is no longer functioning, you just resupplement it with, and just add, again, you can add and put people on thyroid, and basically do a series of blood tests. And I'm not going to go into all. There's the exophthalmic goiter. That's there. The other thing it does is calcitonin. You probably remember that a little bit from bone. Okay. And certainly much more, it's sort of like against parathyroid hormone, which we're going to do next. It's much more active in growing bone. We're not quite sure of the role now. Maybe it would be useful to treat osteoporosis. There's a lot of thoughts. So higher than normal inhibits osteoclast activity. And so that's opposing the actions of osteoporosis and stimulating calcium uptake. And you can see it's these cells, these are the follicular cells that are secreting the hormone. These ones that are deeper in here, sort of in between these big, large follicles, are the parafollicular cells. That's all I have to say about it. There's not a lot to say about calcitonin. I don't think it's clearly understood. Okay, and just as an aside, one of the fellows who was a resident with me. I mean, his dad was maybe the most prominent endocrinologist in the city of Philadelphia for a long time. Back, way back when, as he was getting near the end, and he used, he'd come in and talk about metabolic bone diseases and things like that. We get a lot of information about that. There was never a whole lot about calcitonin, but there was a whole lot about parathyroid. Parathyroid is the biggest single player. You can do without a thyroid, you cannot do without the parathyroid, because that's what regulates your calcium. And if nothing else, advanced physiology is all, it really focuses on that remarkable role of calcium extra and intracellularly, neurotransmission, voltage gated calcium channels all over the place, the role we're going to see in blood clotting shortly. Oh my goodness gracious. So, 4 to 8 tiny yellow brown glands embedded in the posterior aspect of the thyroid. One of the things when you remove thyroid, to be very careful to make sure that those stay there. We don't know necessarily the role, but we do know what these parathyroid cells are, and they secrete PTH or parathyroid hormone or parathormone, and all the names work. So it's calcium 101. And there's a lot, and there's irregularities in this that are seen with a much greater degree of frequency, and it's maybe one of the underlying reasons in osteoporosis for atypical patients. So calcium levels get low. The whole idea of parathyroid hormone is to increase calcium levels in the bloodstream. Okay. And if the calcium levels go up, it slows it down. If it goes down, they pick up. Again, it's the analogy I used with a bone way back in advanced anatomy. It's basically your bones are like a bank for minerals, particularly calcium, maybe a little bit of magnesium. And when you have extra, you put it back in the bone. When you need some, you take it out. And it's just like you get paid and you pay the bills and you get paid again, that type of thing. And it works in 3 areas, principally on bone. Okay. Activating osteoclasts, those resorption bays, that destroys all bone material, not just, again, it's not, that's the misconception about osteoporosis. It's not just about bone salts, it's bone material. So it's weakening the entirety of the bone potentially when it's abnormal. It acts on the kidneys to retain calcium and typically expel phosphate, because calcium and phosphate are linked. Okay. And then lastly, in the intestine, with the aid of vitamin D, it is effectively, those two work in concert to uh, absorb calcium. That's whenever people take calcium supplements, and most of the time we recommend things like Oscal, oyster shell calcium, which is calcium carbonate. If you take Tums, they're calcium carbonate. They have less problems with regard to, let's say, kidney impairment or kidney stones. Inevitably, you'll be taking Caltrate with vitamin D. You have vitamin D enriched milk because it has an abundant amount of calcium in it. All of the above that are there, they're located, not allowed to say microscopically. Those are the way it does. So it enhances resorption of calcium, and if calcium goes in one direction, phosphate goes in the other direction. Even though they're both liberated, mostly the principal bone salt is calcium phosphate. Vitamin D in the kidneys, significant role, and they have to work together. So it's interesting how the system works. Vitamin D has to be activated by a combination of activity in the body, in the kidney, and in the skin, because sunlight plays a role in it. There's quite a bit, and it's a pretty good chart that shows you exactly what happens. That's there. And there's some odd things. Now, we see tumors and they soften. Okay. And again, just look at what we've seen about calcium with heart and nervous system functions. So if you have too much calcium extra like that, it really impacts, adversely the nervous system functioning. Despite the calcium channels, it's just effectively those high levels are altering the electrical balance in and around the nervous system. I don't know how else to describe it to you. And yeah, kidney stones are a big problem. You don't want them. They are more common than you think. There's a lot of things that cause it, and maybe calcium is typically forms as part of them. There's other reasons, as you're going to see as we discuss it: blood, uh, infection sources. There's uric acid, for instance, in gout. There's a lot of things that can lead to crystals in the urinary tract that will cause problems, and they're very, very unpleasant, very painful. Okay, and now the are odd ones. So when you see something like osteitis fibrosis cystica, this is where it's for whatever reason it's focusing on the bones and weakening them and softening them, and they fracture easily. There's a number of these diseases that I have seen these. Okay, um, I've seen them more with connective tissue disorders as well, that played a role in weakening the matrix aspect of it. And the name is on the tip of my tongue. It's highlighted by osteogenesis imperfecta. That is not about calcium so much as it's about the matrix. And what's interesting, the fibers that create the sclera of your eye have, when we look at them in visible light, turn blue. So the giveaway is called a blue sclera. One of those interesting sort of oddball diseases. So hypoparathyroidism is a real problem because in the absence, now we're destabilizing nerves, and we're interacting adversely with the neuromuscular junction. And once you get muscle spasms and skeletal muscles, sooner or later we're going to hit respiratory muscles, and that's when school's out, so to speak. So the parathyroid, there's true parathyroidisms and false parathyroidism. Again, those are the realm of the endocrinologist. When you have when a physician or what we call a clinician, no matter where they are, whether it's a physician's assistant, whether it's a nurse practitioner, whether it's a doctor or a nurse, when you start to see stuff like that, that's usually when we start doing these metabolic and calcium-based workups. Adrenal glands. So we looked at the adrenal medulla. It's nothing more really effectively than a sort of a misplaced ganglion of the sympathetic nervous system. And effectively, it's immediately releasing into the bloodstream epinephrine and norepinephrine. So we don't consider it here. To me, that's autonomic. On the other hand, we have the adrenal cortex. So the so-called glandular portion consists of the outer layer of this relatively small organ, and there are three levels from outside to inside, from peripheral to central, and they all have names, and it wouldn't hurt to know these names that are there. So collectively, since these are all derived from cortisone, we call them corticosteroids. There's subtle variations in the cortisone nucleus. You don't certainly have to know anything about the chemical structure. Okay, and so these are the zones: the glomerulosa, the fasciculata, and the reticularis. I mean, I'll tell you if they're on the test. I don't think they are. But what they make is certainly on the test. So the outer layer makes mineralocorticoids. That's aldosterone. The the mineral is moving is sodium. That's the big player. And probably on a global basis, that's super important. Glucocorticoids, when you forget fight or flight, you get a rush of blood sugar. Okay. Your all of that comes from what are called cortisols. They start with cortisone, they break it down, make it more water soluble. It facilitates a lot of glucose release, which we use in high stress situations. That's glucocorticoids. A lot of times, medications, when someone takes and I was telling you a little bit maybe about it, but I'll tell you again about a dose pack, which we take for poison ivy or severe athlete's foot or an arthritic flare. And I can't even tell you how many I prescribed over the years. Yeah, a lot. The problem with them is they're not necessarily pure. You get a certain, even though they're supposed to be glucocorticoids, there's fluid retention because it increases sodium. It has an aldosterone effect. It pulls sodium in water. On the other hand, sometimes when you're using something that you want to use to pull sodium in water, you'll end up elevating the blood sugar. A lot of times, and I gave a tremendous amount of steroid injections. These are not anabolic bodybuilding steroids. I had no business with them whatsoever. They were, comparably, our knowledge of them was in its infancy when I was in practice, really didn't come to the fore until maybe not, as maybe my last 10 to 15 years of practice. And we certainly didn't have access to those types of things unless someone was using them scientifically in a research aspect. But we gave shots of cortisone to older people with arthritis, to older people with tendonitis, to older people with capsulitis in a joint. You gave them a combination shot of a steroid that was it was interesting because it had a liquid portion that worked right away. One blend, it was a blend of two different types, one that worked right away and one that worked for a long time. And post-operatively, I will tell you that 90% of the times I operated on somebody, we injected it with a short-acting steroid and a long-acting local anesthetic in combination, so it would it's a two-edged sword. You want to keep the pain away, which it would do, but when you inject steroid, it's anti-inflammatory. That's in the glucocorticoids, so they have a marked anti-inflammatory effect. So when you hear grandma and grandpa saying that I just went to the orthopedic surgeon, he gave me a shot in the knee for my arthritis, it's one of these. But again, there's a blend that comes along with it, and the performance enhancing ones, are the gonadotropins. They are testosterone like or testosterone precursors. It's the only place where women make them. So that whatever testosterone activity that they have comes from this area. That's certainly a major contributing factor along with menstruation, is why we see women with a lower blood count than men. Not dramatically so, not problematically so for the most part, but certainly uh, present. And and in men, this is something that plays a role in a variety of things. Maybe this is something that plays a role in male pattern baldness or certain types of baldness that are there. And they're showing you an illustration here of the three different levels: outer, middle, and inner. And now we're down here where you can clearly see the blood vessels sort of embedded in down here into the medullary area. So aldosterone, wider for cortisol and lower still for androgens, and epinephrine and norepinephrine down here. And that's an actual photomicrograph, so that's what it looks like cellularly. Minerales, principally aldosterone. Primary sodium retaining, potassium expelling in the extracellular fluid. And we don't even need to go into all the importance. So the importance of sodium is it affects all of these things and other ions that are involved, and of course potassium with resting membrane potential. So we're not going to rebuild the wheel. Aldosterone is certainly the most potent, big player in the kidneys, blood volume and blood pressure increase, and gets rid of potassium. And so again, we've they've been played with over the years, and for a long time we used diuretics, and I mentioned it before. I think we had other agents that were potassium sparing diuretics because excessively low potassium levels led to heart arrhythmias. And again, I haven't. My knowledge of this came not that I directly treated it. When patients would come in, you'd always get a list of their medications. Normally, they were fairly straightforward. I mean, whatever they're taking. But when you saw something unusual, you do what everybody else does. You look it up. So aldosterone, relatively short-lived. Sodium potassium pumps, exchanging sodium for potassium. And again, the renin angiotensin aldosterone mechanism, big player. Let me go back just a smidge. If there's increased plasma concentration of potassiums, we excrete them. ACTH would and that's what his role is. Adrenocorticotropic hormone from the anterior pituitary. It jogs all three of these. And again, the opposite effect is that ANP, that natriuretic peptide. Natriuretic means to push out the sodium, urese or diurese, they're urinated out. So decreased blood pressure. Remember, we talked about those cells in the juxtaglomerular apparatus and the renin release. And renin basically starts the conversion of the precursor substance eventually into angiotensin 2, and that's the big player. Then the aldosterone. So increased influence it as well with potassium to release aldosterone. Again, we've got to get rid of the potassium and bring back in the sodium. Okay. And the low levels and have ACTH, small increases during stress, so it's useful. People used to get injections of ACTH to deal better with stress because we didn't really understand it very well. It's interesting because my dad did this. I mean, I'm feeling a little tired, a little lethargic. I went to see the doctor and he gave me a shot of ACTH. Now, whether it was in his head, which is possible, or whether he actually felt better, I don't know. Uh, I don't know if there were adverse effects But as I've told you before, his death was related to heart disease, and there were a lot of other mitigating factors involved in that for a man who presented very, very healthily. And HANP again in the heart response because high blood pressure stretch those atria and they'll block the renin and they'll block the aldosterone and effectively limit and recently will increase the diuresis indirectly of sodium. It's there, nice chart to cover it. And this is one of the problems with chronic steroid use. We have aldosteronism, hypersecretion usually due to adrenal tumors, okay, hypertension and edema, as you might guess, because we're taking a lot of fluid, and pushing out the potassium. Now you have particularly heart arrhythmias and nerve and muscle irregularities. So we do see aldosteronisms. You're going to see some change disease-wise things that are interesting as well. Bigger problem with glucocorticoids because the go-to for forever with before we had this array of what we call biological specific substances we're going to talk about in the immune system unit to combat autoimmune diseases. We didn't really know what they were about. We called them connective tissue diseases back in the day, and there wasn't a whole lot to treat them with. So what do? We basically knee jerked. We knew some things worked on Crohn's disease and ulcerative colitis and rheumatoid arthritis. And we basically, most of them were sort of put together with a certain amount of steroids. And when it flared, we added more steroids. And when it stopped flaring, reduced the steroids. I mean, when I first started studying rheumatoid arthritis, I worked with a legend down in Virginia who had written some of the original stuff on when we began to understand a bit about autoimmune diseases in the early days, because we were starting to talk about all these neat HLAs, histocompatibility locuses that we're going to look at in the immune system. One called B27, which he wrote his research on, and that was 1936. How is he treating rheumatoid? And this was a vet's hospital. They had a ton of guys and gals with rheumatoid, mostly guys. They were using gold. Injections of gold were basically suppressed autoimmune activity at the time. They don't use it now. Okay. Because heavy metals have poisonous effects, but they were using something called myocrysine. They were mixing it with steroids. They were mixing it with painkillers. They were mixing it with muscle relaxers. They were mixing it with non-steroidal anti-inflammatories. And it was just like he said, it's like a recipe. He said a little bit of this and a little bit of that. Whatever works, we work from there. So what they basically do are maintain constancy in our glucose levels, maintain blood pressure because they help the vasoconstrictors. They play a role. So they're useful in a lot of systems, and they're all variations of this. So if you go out and get anti-itch cream, it's a hydrocortisone cream, 1%. Very effective, can't hurt you. Very useful because it stabilizes membranes, has anti-inflammatory effects on a topical basis that are there. So again, responses to ACTH, again, as known as corticotropin release hormone, is the one that comes from the hypothalamus rather than the ACTH from the anterior pituitary, this CRH from the posterior pituitary. And standard negative feedback. Again, lots of this is pattern I commented on before. Very careful when it comes to cortisone how you discontinue it because it can have adverse impact on people. So we always make sure when we do these things, we tend to our last doses are in the morning because that's naturally when you're set up to release them whenever you start your day. Morning might be the wrong term. So all of these things can impact it, and yes, we have overrides with it that are there. So basically, all of those things primarily impacts gluconeogenesis, which you're familiar with, blood levels of glucose from non-sugar sources. It's not coming from glycogen, fats, and proteins. So, and the good news for this, fatty acids for fuel, so glucose is saved for the brain, is kind of what they're talking about. And blood pressure rises to quickly distribute nutrients to cell. So think of it in stress. What you're trying to do, you're trying to save the glucose, use other sources for glucose. There's a lot of benefit to it. The trouble is there's adversities. So Here they come: cartilage and bone formation. And I saw this in patients. A lot of times, you would only, well, I'd have to tell people we can only inject your joint 3 times a year, maybe every 3 months, maybe every 2 months, depending, because of this cartilage and bone formation. You could weaken it, cause a fracture. Okay. Inflammatory chemicals, for whatever the reason is, and most of us think it's membrane stabilization. It's almost like, remember, cholesterol enhances membrane stability and the typical phospholipid bilayer. That's the other component, as well as proteins and phospholipids, is cholesterol. It certainly depresses the immune system for that reason, and that's mostly because of the chemicals, and it disrupts all of these functions that are there, but they're useful. Arthritis, they're still a go-to with allergies. A lot of people use today the most effective way of dealing with your clogged nose, and maybe you're getting allergies in the spring, summer, or fall, and a lot of it, getting myself included. Now it's perfectly approved. You get those cortisone sprays. You can buy them without a prescription. They work great. They're safer in opening up clogged passageways than using the other sprays, which would cause nosebleed and damage the lining. There's a whole lot to that, and that's the undesirable effects. So here we go. 2, most notably Cushing's. This was the problem we saw a lot, not only with tumors, but with people who are on high doses, and we didn't have much choice to get rid out of them. All the depression of that and inflammation and all the stuff we talked about before. So it can be certainly a tumor, understand that. A tumor in other organs, we can understand that. Adrenal cortical tumors, we can understand that. The big problem was overuse of corticosteroids. And you would literally see people change when they were on this. I'm sure I commented on when we talked about the year, this gal who was just strikingly attractive. When my first wife and I got married, she got the last date in June. We had to get one 2 weeks later. She was a relative of a relative. We saw her at all weddings and bar mitzvahs. And all of a sudden, a year after the wedding, she was unrecognizable. She hadn't been years. The only thing they could treat her with was a bunch of steroids, and she looks like the picture you're going to see. Moon face, you could, unrecognizable. Must have been 50 pounds of different kinds of weight that were there. This is the other one, and this is rare, and this is more problematic because the Cushing's, assuming it's not tumor, you could just, nowadays you could find other agents and limit the steroids, but not so with Addison's. Addison's is just not working. Okay, so you have less glucose, irregular sodium levels, all of these things. Yeah, now if you can recognize it, you can use this. What's interesting about it is the ACTH, again, is another one of those hormones, a little bit, and I mentioned it just in passing, that works on melanocytes. So one of the giveaways, and one of the problems with these folks with Addison's disease, they look awfully healthy. It looks like they're out for a tan, they're out on the beach. Okay. Typically, they're slender, but physically, they're very, very fragile. And we didn't understand it as well. And the most famous of all these individuals was a president who was assassinated in 1963 named John F. Kennedy. And JFK was, frankly, given the state of medicine then compared to what we have today, would likely not have had a very long life. And I think he was 46 years old. I think he was inaugurated. I'm going to say he was born in 1917, so I think he was 44 when he was inaugurated and died roughly at 46 or 47. And he was taking a ton of different medications, and it wasn't the only stuff. They were giving him other stuff that wasn't good for you. There's a lot of anecdotal evidence about using stimulants and things like that because his physical health was not particularly great. And enough said about that without getting into the history of the presidency, which is definitely a different course. So here you can see before, after. Just the guy I was telling you about with worse. The gonadotropins, relatively weak. These are famous, and they're famous because of a guy named Mark McGuire. You could buy these supplements in GNC, and what and one day we were in the locker room and it's Cardinals, and he's hitting a gazillion home runs and ended up with like 70, whatever he did in that year. And Sammy Sosa had 66 in 1998, very, very famously. And what happened? They found a big jar of Andro. So, I mean, he could say what he wanted in front of Congress. He's a steroid user. And to be fair, he probably would have got hit 50 as a skinny rookie, hit 50 home runs. Okay, back with the A's, at least 10 years before that, perhaps. So understand that that's so. Again, it's a precursor substance. This is a lot of these designer steroids that athletes use are from here. Why? Because they play around with them chemically, and it's difficult to find tests to be able to identify them. That was always sort of the clever thing that these labs would do. And truly, this was one of the things that played around with Barry Bonds. And I'm sure I told you that story, but never hurts to tell it again. I mean, we met not formally, said hi to Barry Bonds. We signed autographs at the Y in Oil City when my kids were swimming at like, my daughter maybe at most 5, probably 4. My oldest 7 at a swim meet, and he's over in the gym signing autographs, and he comes in to say hi to everybody at the swim meet. Nice young guy. This is 1986. I'm telling you, when he was a rookie, or 87, and he was obviously highly touted. Great player. His dad was a great player, and he was maybe 2 inches taller than I am at the most, and couldn't have weighed more than 165 pounds, 170 pounds. And then, when he was doing steroids, 15, how many ever years like later than that, 20 plus years later than that, 17, he was about 6'1", 6'2", and weighed about 220. Not normal. Okay, so all these things: onset of puberty, secondary sex characteristic. We think it's sex driving women because that testosterone more of a player than that. Estrogens in postmenopausal women, because again, those are chemicals: estrogen, progesterone, testosterone, very similar from an organic chemistry perspective. So, and this is famous. We have these adrenogenital syndrome, pardon me, and men don't notice it, but it masculinizes women and prepubescent males. So in boys, it looks like that they major early. And in women, it's really not. As you can see from the description here, troubling to say the least. But at least it's recognizing the things you can do about it. And the medulla really doesn't. These are the cells where it makes the epinephrine and norepinephrine. I want to mention it in passing. Vasoconstriction, heart rate, increased glucose. We all know about this because they're stimulants. And here it's getting it from the liver. That's glycogenolysis. It's a little different, not gluconeogenesis so much. And again, we know diverting the blood to the heart and skeletal muscle, not to the brain. Brain always gets its share. That's, again, they don't know what they're doing when they write these PowerPoints. Both hormones have the same effect, but the but's important. Epinephrine, bronchial dilation, blood flow to skeletal muscles and heart. Norepinephrine, more of an influence on peripheral vasoconstriction and blood pressure. It's this when they started to use something called, and you have to look up, called Metabolife. It was made from ephedrine, which is the parent compound for a lot of for Sudafed, which was taken off the market, and was something that you could make into amphetamines. And when I told you about those anecdotes about the football player, they put him on a weight loss product. That was it, and he died of hypothermia. He was enormous, but he was all pro for the Vikings. Young man under 30, pitcher for the Orioles, same deal. Even though he wasn't nearly as heavy, but maybe weighed 230 to 250. So that's because of this than that. It's not so much bronchodilation and blood flow. It had more to do with blood pressure and heart-related, because that pitcher did die of heart-related complications. And so you can just take a look at these different pictures. So your hypersecretion is, again, all the things you expect: sugar, metabolic rate, palpitations, etc. It's one of if you're a med student, you hear about this. It's one of those things you always look for. It's called PHEO, short for pheochromocytoma. Those chromaffin cells are very distinctive, and if you suspect somebody had, you can't account for why they have hypercalcemia, all these things here, high blood pressure. In the back of your mind, you're looking for a PHEO. In the old days, I know what they do today. You used to collect urine for 24 hours and look for the breakdown product of epinephrine called vanylmandelic acid. Not that it counts. Nice chart. Pineal gland, don't know a whole lot about. Melatonin, which is serotonin based, very useful for sleeping. Yes, it plays a role in a lot of, again, we would collectively call them rhythms, various cycles that we have. Okay. Uh, all of these types of things. Yeah, maybe some antioxidant detoxification in certain cells. Melatonin basically some helps us sleep. You can buy it as a supplement. Be careful if you do, because unfortunately, some people, it really has a profound effect. They wake up very tired, drowsy, and if you get up and you can hardly get yourself to work, and you're in a car, you might have a problem with your reaction time. So, first time you take it or the second time you take it, make sure you take it in a controlled environment. In other words, you have to get up and go to work the next day, so you can see just how woozy you are and adjust the dose or the timing. If that's what you, because a lot of people have trouble sleeping. But pineal gland, we think about rhythms. It's a lot of not sure. Same illustration. Saving this because it's diabetes. Saving it because it's diabetes related. Saving it because it's diabetes related. We'll do all this and we'll do all that and we'll do all that because it's so terribly important. I have a lot of information to share with you. Testosterone and estrogen. Testosterone, we all are familiar with it. Maturation, secondary sex characteristics, sperm production, reproductive organs, okay, placenta, estrogen, progesterone, HCG, which we'll talk about when we start doing the repro unit and the growth and development unit, adipose tissue. And so the testosterone and estrogen, progesterone, and HCG, we revisit again more than once. Adipose leptin, increased energy expenditure, it really, it's from an accumulation of fat cells. We actually need it. Okay. For normal growth and development, we need to have a certain amount of fat, more so women than men. Okay, because it can really impact puberty and development significantly, and we'll get into that. And these are other ones, and again, fat levels without, there's so much science behind it, and we're beginning to understand more and more about what why things combat insulin and why I think we're more sensitive to insulin. It has a lot to do with body types and amounts of fat, and it's, I don't have enough expertise to tell you about it. We'll talk about the gastrin. We'll get into again when we get to GI. Ghrelin is sort of a non-specific hunger inducer. We'll get in secretin and cholecystokinin, and because that's the gastrin is the big player in the stomach. These are the big players in the small intestines. And again, these are, again, subtly, typically what we do is there's a very interesting sort of tug of war between insulin and glucagon. And that's about all I can tell you about it. It's at certain times we want to be more, the insulin has to play a role. It has a lot to do with dietary things, normal metabolism, the atria natriuretic ANP we talked about before, the renin we talked about before. A quick word on erythropoietin. It's made in the kidneys. It's the principal stimulus, certainly in women and in men, as well as testosterone, of RBC production. It is one of the earliest agents that we started to make because it's a relatively simple polypeptide. It was manufactured and called Procrit. I don't know what name it goes through today. I had patients with it, and they're mostly diabetics because they couldn't make the erythropoietin because their kidneys were failing and they were heading toward dialysis. And to combat anemia, they got shots of Procrit every whatever X number of months. Very expensive shots, as you might get. But the kidneys, that's people with kidney disease suffer with anemia. That's well known. Osteocalcin from osteoblasts. Again, uh, so typically, if we're building bone normally, okay, we want basically, we're not trying to do it to utilize fats. We're going to use carbohydrates. We don't want to store fats excessively. We want to handle glucose, and insulin plays a role in this. Okay, and we begin to see that when we talk about type 2 diabetes, very interesting. Okay, and again, I can only present you a little bit of it. There's so much we're looking at now because unfortunately, that's the part that grows. There's a lot more people with type 2 than type 1. And skin, again, vitamin D, it has to be activated there. Okay, and in order to get it here, we have to place a role for it to be activated in a variety of areas. Both we have to get it utilized in the gut. Okay, all of these types of things that are there. So the vitamin D and the other agents that are part of vitamin D are really important. So my vitamin D levels were low. I think I told you. I've started to pick them up again. I used to take vitamin D supplements. I don't. I didn't for quite a while. Now I'm doing it again. I think it's a real good idea to have your levels higher. Most people are on the low side, even though they're normal. Mine were still normal. And the thymus, these are all about uh, whatever role they play is in development of T cells, and we'll get to that. And really, they're more paracrines because they're working on cells that are maturing in the thymus itself. And so that concludes everything but diabetes. So I'll do the diabetes and I'll get working on the blood a little bit. I know we started a little bit with the different sections of blood, but we'll get into it full bore on the rest of Friday and certainly on Monday and even Monday back in the lab a little bit. Thank you and hope you enjoyed the presentation.